Good evening, friends. Hope all of you are doing well. Today, entire world is suffering from the effect of corona or COVID-19, and we anesthetists are involved in the management of corona patients in the operation theaters, in the ICUs. I am going to talk about COVID-19 patient and regional anesthesia especially, because this is very important, especially for freelancing anesthetists and also for anesthetists who are working in big hospitals, because regional anesthesia is a safer option as compared to general anesthesia in these patients. So we will discuss about spinal anesthesia, epidural anesthesia and peripheral nerve blocks, how to give it and what precautions should be taken before giving regional anesthesia in these patients. I have prepared this presentation from this guideline. There is COVID-19 guidance for regional anesthesia, neuraxial and peripheral nerve blocks. This is by ESRA and ESRA Society. So I am thankful to them for publishing this guideline, and I have taken most of the things from this guideline only. So, as I said, anesthesiologists are at highest risk of COVID-19 infection, because we are dealing with airway, we are dealing with patients in very close communication, so we are at highest risk. GA with airway management is a potential source of aerosol generation, because when you give GA, either when you do intubation or extubation, patient will have high generation of aerosol, and you are very close to the patient, and there are all chances of infection if you don't take proper precaution. And there is different guidelines and different sources for this, how to give GA in these patients. Airway management increases the risk of infection to healthcare profession up to 6.6 times. So if you are managing the airway, you are 6.6 times increased risk of getting COVID infection if you are treating the patient of a COVID. So RA is considered safer. So how to prepare and plan when we are giving regional anesthesia or neuraxial anesthesia? There are mainly three types of patients. COVID-19 negative patient, I doubt nowadays any patient can be positive patient. A patient might be asymptomatic, you don't take care and you get infection from the patient. COVID-19 positive patients and suspected or patient under investigation. So if we talk about COVID-19 negative patient, as I said, we should follow institution guideline, regular institution guideline if it is a confirmed negative patient. But once community spread starts, all cases must be presumed to be COVID-19 positive. So consider all the patient as a COVID-19 positive and treat accordingly. So what will you do COVID-19 in positive patient or patient under investigation? Usually RA is not considered aerosol generating procedure. There are less chances of aerosol generation unless patient coughs or sneezes. But we have to take regular contact and droplet precaution, like we have to use surgical mask, eye protection with goggles or with glass shield, surgical gown and double gloves should be used. The use of N95 mask or similar powered air purifying respirator is not generally needed, but may be considered for prolonged close contact with positive patient in a closed setting. This is the guideline, but I personally believe we should use N95 mask in all the patient, and we should take all possible precaution in all the patient regarding whether patient is positive, whether surgery is prolonged or contact is more. We should take all, because we don't know when surgery will be prolonged or when we need to manage the airway. So we don't know about it. Sometimes we have to suddenly manage the airway, and if you are not properly prepared, then you are at increased risk. So always use all possible PPE while doing the procedure. All patients should wear a surgical mask to restrict the droplet spread. Always ask the patient to wear the mask during the procedure. Sometimes patient will say that I am not comfortable with this mask, but it should be instructed to patients that you will have to wear the surgical mask all the time during surgery. Avoid high flow oxygen using nasal prong. If you are using nasal prong oxygen, there will be generation of the droplets and it will spread in the atmosphere. We have to avoid nasal prong and high flow oxygen. If the patient needs supplemental oxygen, use oxygen mask with lower flows. The flow of supplemental oxygen should be kept to the minimum as possible. The surgical mask can be used to cover the oxygen mask to limit the dispersion of the droplets. So when you apply oxygen mask, always cover it with the surgical mask to prevent the spread of the droplets. The regional anesthesia procedure should be performed in the operating room and not in the block room. This is very important because in the block room or in the area where you perform block, sometimes there are other patients and you will expose those patients to this positive patient, and there are chances of the spread of infection. So always take the patient inside the OT, don't use block room and give the block or regional anesthesia there only. The most experienced person should perform the regional anesthesia. This is very important because you don't want to take any chances. You want the effect 100%. Suppose you are doing a surgery under a block like radius fixation or humerus fixation, and if you are allowing your resident to give block and block doesn't act, and you have to convert it into GA. So it is not a desirable thing, especially in the era of the COVID-19 infection. So always ask the experienced person to perform the regional anesthesia. The donning and or personal protection equipment should occur before entering the room. So always wear all PPE before entering into the procedure room. Equipment. Bringing a cart or trolley with drugs and equipment to the procedure room should be discouraged. Don't bring all the drugs and trolleys with drugs inside the operation theater. You will take this to the OT. Patient will generate some aerosol and it will go on their trolley and it will spread to other patients. So don't allow it. The required equipment and drugs should be prepared and packed inside plastic bag before the procedure. So only take the required drug inside the operation theater and it should be packed in the plastic bag. The ultrasound equipment including ultrasound transducer should be protected from contamination using plastic cover. So cover the probe with plastic, whatever you are using, like cling wrap or camera cover or whatever you are using. Always wrap the probe, always cover the ultrasound machine with the sterile plastic wrap so that aerosol transmission can be reduced, and always minimize number of persons inside the procedure room. Always keep adequate staff, like sometimes you need assistance, so keep adequate staff, but don't allow more person than required. So what will you do when you are doing spinal and epidural? First thing need to do is rule out thrombocytopenia. There are reports, there are studies where they have shown that in patient with corona there is thrombocytopenia. So always rule out thrombocytopenia first, because if platelet count below 75,000, then look for the risk benefit ratio and then only go for spinal or epidural. Use routine asepsis. All routine asepsis should be practiced. There is a study where they said that coronavirus stays on the plastic drapes more as compared to paper drapes. So if you have paper drapes, then use it as compared to plastic drapes. Don't allow CSF to drip freely through the spinal needle, because there are studies where they found coronavirus in CSF also. So if you allow the CSF to drop on the operation theater table or on the drapes, there are chances of coronavirus spread. Use adequate dose to prevent conversion to GA. Suppose if you have given smaller dosages, or you have used a short acting drug and surgery lasts longer, then you will have to convert it into GA. So choose the drug wisely, so that your surgery can be finished under the spinal anesthesia or epidural anesthesia. There is no specific dose adjustment recommended for this positive cases. For continuous epidural, adjust dose to minimize requirement of top-up dosages, because if your staff goes for the top-up dosages, he or she will be in the close contact of the patient, and there are chances of spread of the corona to the healthcare professional who is going to give this top-up dosages. So adjust the epidural so that you require minimum top-up dosage. Report of excessive hypotension are there with COVID positive. When you are giving spinal anesthesia in COVID positive patient, there are some reports of excessive hypotension. So be prepared with vasopressors if required. Use negative pressure room if possible. If your hospital has negative pressure operation theater, then use it, because positive pressure inside the OT will spread the virus in all corridors and other OTs also. Dispose all material properly after completing the procedure, because there are chances of spread with all these spinal needles or epidural needles or traps. Charting should be done outside procedure room. Don't do it inside. No need to do it inside OT, because if you take these charts and if you are doing web charting, laptops or computers inside the OT, there are more chances of droplets on those things, and it can spread the corona. So it should be done outside procedure room after the procedure, or you can ask someone to do charting from outside of the operation theater. What if patient develop PDPH after spinal or epidural? We have to use conservative measures. There are not a big study, but this must be the guidelines. We have to go for conservative measures first. Avoid nasal spinopellet and recently there are reports that nasal spinopellet and ganglion block work well in PDPH, but don't use it, because chances of droplet spread and close contact are more with nasal spinopellet and ganglion block, so avoid it. Avoid blood patch if possible. Try conservative measures first, because we don't know in positive patients. We collect the blood from the patient and we are injecting the drug in the epidural spread. What will happen if it goes into CNS? We don't know what is the actual problem. So we have to avoid it as far as possible, especially in the patient with active COVID status. We can do it after patient becomes negative, but avoid as far as possible. Peripheral now blocks. Choose your block to minimize respiratory complications. Suppose if you are giving upper limb block, avoid interscalene block wherever possible. Avoid supraclavicular, because phrenic nerve palsy is more with both this block, and with supraclavicular block sometimes you can precipitate pneumothorax. So this block should be avoided whenever possible, and it should be replaced by other blocks. Use ultrasound if possible, because with the use of ultrasound you can reduce the dosages, you can prevent the phrenic nerve palsy, you can prevent the pneumothorax. When you are reducing the dosages, there are less chances of blast where you require intubation, so it should be avoided. Avoid pre-procedural sedation, because sometimes with sedation patient will have respiratory depression and you will need to handle the airway if patient develops severe respiratory depression. Use additive wisely to prevent immunocompression and sedation. Suppose if you are using dexamethasone, it can cause some immunodepression, and with drugs like clonidine, sometimes patient will have sedation and it will hamper the respiratory status. Catheter should be used after looking at risk-benefit ratio, because when you are putting the catheter, you have to ask the paramedic staff like nurses to give top-ups or changes sealing, so more patient contact. But when you are using the catheters, you will require less opioids, which is respiratory depression. So risk-benefit ratio should be checked and use catheter accordingly. Don't use facial plane block, which require reposition of the patient after. Suppose a patient is for laparotomy and you want to give blocks after GA. So give tap block or rectus sheath block where you don't require positioning of the patient. Avoid blocks like erector spiny block or thoracic paravertebral block or quadratus lumborum block where you require to reposition the patient, because when you reposition the patient, there are chances of dislodgement of the endotracheal tube with the circuit, and there are chances of aerosol spread. So in such cases, use blocks like tap block or rectus sheath block rather than using the blocks which require lateral position. Avoid last. Use the dose, calculate the dose properly to avoid the local anesthetic systemic toxicity. Because if at all last occurs, you will require resuscitation, you will require intubation, and there are more chances of infection to healthcare professional when you are doing intubation or resuscitation. So calculate the dose properly, use ultrasound and prevent the last. Avoid block if you can achieve analgesia with systemic. And suppose if you have given GA and if you want to supplement the block to provide analgesia, then look at the risk benefit ratio, whether if you can manage the pain with systemic agents, avoid the blocks. Monitoring and conduct. Test block success before proceeding for surgery. This is very important. Check whether your block is working or not, spinal is working or not, epidural is working or not. Give enough time before asking the surgeons to go ahead, because sometimes with blocks like sciatic block you will require more time. So give adequate time for a complete block, then only proceed for the surgery. Excessive or deep sedation should be avoided because it can lead to respiratory depression and you will require intubation. If you need to convert to GA, take all necessary precaution before intubation. Use all PPEs. You take all precaution to prevent COVID spread to yourself. Patient should wear surgical mask all throughout the procedure if surgery is going under spinal or epidural or block. So ask the patient to wear the surgical mask all throughout the procedure. When you end the case, patient should be monitored in the operating room until safe and before transfer to COVID-19 design area to the hospital as per local guidelines. So don't ship the patient to the recovery area. Directly ship the patient to the COVID-19 designated area. Till that, monitor the patient inside operation theatre only. It has been shown that the risk of transmission is highest during the doping of personal protective equipment. So when you are removing the personal protective equipment, if you don't take proper precaution, there are high chances of infection. So extra time should be allowed for while wearing and removing the PPE. The presence of an observer is recommended when you are doing all this. Simulation sessions should be conducted for training staff for wearing and removing the PPE. Any reusable equipment utilized during the procedure should be disinfected as per institution guideline and then only use. So this is the guideline for regional anesthesia and COVID patient. If we summarize the guidelines, don't appropriate PPE before doing procedure, take extra time to dope and use an observer. RA procedure are not considered aerosol generating. The use of N95 mask or similar mask is not considered necessary, but I will say always use it. The use of N95 mask should be considered for surgical procedure with a significant risk of conversion to GM. All patients should wear a surgical mask to restrict the droplet spread. Ensure the use of plastic covers to protect ultrasound equipment. Choose the right procedure. The use of RA is not contraindicated for COVID-19 patients. RA is prepared for providing anesthesia care whenever possible. Prepare and pack the required drug in a plastic bag. Don't take all the drug inside OT. Use block that reduce the respiratory interference such as axillary or infraclavicular block as compared to interscalene and supra. Risk benefit should be considered for perineural adjuvant and continuous perineural catheters. Currently, no dose adjustment for RA is recommended. Use ultrasound guidance whenever possible. RA should be thoroughly tested before proceeding with surgery to minimize the need for conversion to GA. Use minimal supplemental oxygen. Rule out thrombocytopenia before neuraxial procedure. Watch and be prepared for hypotension after neuraxial anesthesia. Postpone epidural birth patch if possible until recovery from acute infection. So this is the summary of the guidelines which I have discussed. And this is last but very important. When you go to home after completing your operation theatre duty, take shoes off before entering the home. Spray alcohol tap and bottom alcohol at the top and bottom of the shoes. Also, due to clothes, cell phone, glasses, keys, work utensils and computers, etc. Throw away any receipt or papers. Go to where you can take your clothes off and put them in the washer immediately with hot water. Don't touch or sit in any chairs or bed. Go to the bathroom directly to take a shower with soap. Brush your teeth properly. So clean yourself up before exposing to your dear ones like your kids or parents. Then only you can hug your family. So take care of yourself, take care of your family, take care of your kids, take care of your parents, take care of your spouse, and do the duty which you are doing it for society. So your safety is as important as of patient. Thank you. Namaste.